Good afternoon, everyone, and welcome to this regularly scheduled meeting of the Public Health, Environment, Civil Rights, and Engagement Committee for June 24th, 2019. My name is Philippe Cunningham, and I am the chair of this committee. With me at the dais are Council Members Cano, Schrader, Vice Chair Gordon, Councilmember Johnson, and Council Vice President Jenkins. Please let the record reflect that we have a quorum and can conduct business of this committee. Colleagues, on our agenda, we have 6 items, 4 for consent, and then we will have 1 discussion item. I'll get to that shortly. So the first item is authorizing a site agreement with Americorps in total amount of up to $12,000 for a period of 1 year to host 2 Minnesota Opioid Response Corps or more Corps members engaging and designing framing the work of the Minneapolis Health Department in response to recommendations from the Mayor's Task Force on the opioid epidemic. I just want to pause here quickly and say we have 2 amazing folks who have been working really hard, Carl and Maria. So they've been working really hard, and so I just want to give them a shout out for the work that they've done already, really showing that this is a wonderful investment and a great opportunity to grow and develop leadership. Item number 2 is accepting a grant from the Minnesota Department of Agriculture in the amount of $53,615 which is for a project period through December 31st of next year for needs-based technical assistance to new and established retail food establishments in Minneapolis. Item number 3 is accepting a grant from the National Association of County and City Health Officials, NACHO, not Nacho, but NACHO, got it, in the amount of $200,000 for technical assistance in establishing an opioid response program. Item number 4 on our consent agenda is referring to staff and ordinance amending Title II, Chapter 40 of the Minneapolis Code of Ordinances related to administration, workplace regulations, adding a new article establishing freelance worker protections. And colleagues, I will also be referring to staff item number 5, which is under discussion. For discussion today, I will be referring it to staff for an ordinance relating to administration, preventing wage theft, adding overtime and break requirements, and restricting city contracts from being awarded to entities with outstanding wage obligations. With those 5 items, I move approval. Are there any questions or comments from my colleagues? Council Vice President Jenkins.
Thank you, Chair Cunningham. I just wanted to speak a little bit to item number 4, the Freelance Worker Protections Ordinance, which really works to seek to protect a very rapidly growing segment of our labor force, which is freelancers, contracted workers like Uber and Lyft, and all of these sort of gig economy jobs that are occurring, and this is an attempt to try and ensure protections and fairness for those workers as a part of our economy. I'm also pleased that it includes some of the sex workers who work in our in these establishments here in the city of Minneapolis, and to help protect their incomes as well. So just wanted to acknowledge this is a great referral, and I'm happy to support it.
Thank you so much, Council Vice President. Anyone else want to speak to any of these items? All right, seeing none, I'll just go ahead and add to that I'm really grateful and excited on this work between wage theft and freelance worker protections. As we are seeing our economy shift, it's really important that we as a governing body adapt to these changes that we are seeing within our economy, and I'm grateful to be able to be a part of this work. So with that, the motion to approve is on the table. All those in favor, please signify by saying aye. Aye. Those opposed say nay. The ayes have it, and that item carries. So now we have our 1 discussion item for today. which I'm very excited about an update on. It's the Fast Track Cities. So we are going to be receiving and filing an update on the Fast Track Cities initiative, which aims to build upon, strengthen, and leverage existing HIV programs and resources to accelerate locally coordinated citywide responses to end AIDS as a public health threat by 2030. Who do we have starting off first? All right, we have Deputy Commissioner Noya Woodrich. Did I say your last name right? Yep. All right, nailed it. Who is going to be kicking us off today. Thank you so much, Deputy Commissioner.
Thank you, Council Member and Chair Cunningham and Council. I'm going to be joined by Sarah Sheely today, but I'll get us started. So a little bit of background for Fast Track Cities. Fast Track Cities is actually an international initiative. There are many, many dozens of cities across the globe that have signed on as Fast Track Initiative cities. The goal of the initiative is to end AIDS as a public health threat by 2030 around the world. And implementation is designed to meet four main targets. Those targets are 90% of people living with HIV know their status, 90% of people who know their status will receive treatment, 90% of people living with HIV on HIV treatment will have suppressed viral loads, and there will be 0% stigma and discrimination against persons living with HIV. Before we moved on with the presentation, we have a couple of our partners that in the audience that have helped us put together this plan, and I wanted to give them a moment or two to say some words about their interest in the project.
Thank you so much.
First is Jake Maxon, and he works with Hennepin County on their HIV/AIDS project.
Great, thank you so much. Welcome.
Thanks for having me today, council members. So my name is Jacob Maxon. I coordinate Hennepin County's strategy to end our HIV epidemic, Positively Hennepin. And I just want to say that ending HIV has always been at its core civil rights and socioeconomic issues. And I'm happy because of this committee's focus for your guys' support and overview of this work that we are doing. So to break down where we're at, I kind of want to talk about opportunities and challenges we face in stopping HIV. First, I just want to thank the leadership of Health Commissioner Musicant and Noya and the rest of their staff. Noya is new to this world of HIV policy, and I have to say she's always brought the right empathy and curiosity to this work. So it's been a pleasure working with Gretchen and the rest of their team in Noya. So today we know that people living with HIV, when they're able to take their medications as prescribed, it's impossible for the virus to be transmitted sexually. So treating HIV will stop HIV infections. We also know that new infections can be stopped when HIV-negative people use a pharmaceutical intervention called PrEP, short for pre-exposure, so before exposure to HIV, prophylaxis, which is just a fancy word for prevention. And though the community has known this for a while, our public health research is finally catching up to the fact that access to affordable housing is essential health care for people living with HIV. So these are all the things we know and all the opportunities we have to stop this epidemic. But the challenges are big and they are still remaining. HIV has always hit hardest among people whom our society forces to the margins. Men who are gay or bisexual, folks who are Native, Black, Brown, and are transgender. And as housing and pharmaceutical costs rise, HIV's disproportionate impact on these communities will become more severe. And as I prepare the annual progress report on Positively Hennepin, I can see that these disparities, particularly how they affect our county's African American and African-born residents, is increasing. And this is a a big fact that should all give us pause. But if the course of the epidemic does not change, half, 1 in 2, all black men in America will live with HIV who have sex with men. So half of all black American men who have sex with other men will live with HIV. And that's really a possibility we have to stop. And considering these rising disparities, something big for us to consider. Obviously there's a big humanitarian cost to this, but the economic costs are also high. Roughly 4,700 Hennepin County residents live with HIV today. And the cost of medical care alone for these residents is $108 million annually. If we stop new infections today, the lifetime medical costs for these county residents living with HIV will total $1.8 billion for just medical costs alone. And that obviously says nothing of the human impact or the broader economic impact of the virus. So these are big challenges, but as I said, we've got new opportunities both from pharmaceutical knowledge and the energetic work that's happening here with my collaborators and partners on Fast Track. So thank you very much.
Thank you so much for being here. I have a question or comment from Council Vice President Jenkins.
Thank you, Chair Cunningham, and thank you, Jake.
Yep.
Yeah, thank you for that presentation and the work that you guys are doing at Hennepin County. I'm wondering you named 3 communities which I know are really challenged with HIV and AIDS, but black heterosexual women are equally as challenged, and I'm deeply concerned about that community and not hearing a lot of support, resources, awareness from some of the agencies that are involved. What is Hennepin County doing around targeting black women, African women who are living with and, in those populations to be potentially infected with HIV and AIDS?
So focusing on African communities, particularly West African communities, which Hennepin County has a large population of, we are, and I am in particularly working with the West African HIV Task Force. So this is a true grassroots organization that, through a partnership with the State Department of Human Services, we've provided them, I think, around $20,000 in the past year to create a grassroots community-led strategy that will design messages for African residents that speak to them in a culturally responsive manner. And tomorrow, with this task force, I am meeting with a representative from the state health department to talk specifically about how HIV, based on our knowledge of the epidemic surveillance data, how HIV is impacting West African communities and African communities across the state as a whole. And not only, it's important for me to say that we will be talking about what we do know. For example, the disproportionate rates of new infection, the disproportionate rate of African Minnesota residents living with HIV. But we'll also be talking about what our data can't tell us. Right now, unfortunately, our surveillance data for African residents who've become infected with HIV really lacks risk factors, so how an infection occurred. So we're going to be talking about that and how that information is essential to kind of responding to HIV from a community-led and government perspective, and what we can do to make that situation better. As far as what Hennepin County's administration of our Ryan White program is doing, we are really focused on how to make our services culturally responsive for all people. who are impacted by the epidemic. So what that means is if you are an African American woman who needs HIV care, we want to make sure that the providers we fund are able to provide that care in a respectful and compassionate way. So we've released a new set of culturally responsive standards that our providers will be needed to follow, and the implementation on these new culturally responsive standards just began in the past year.
Can I follow?
Yes, please.
Are there any organizations that specifically target or identify women and women-identified individuals for their programming?
I am not aware specifically about just a gender specific, like women specific, but we do have the African American AIDS Task Force, which focuses on African American people, and we also have Sub-Saharan Youth and Family Health Services, which focuses on providing HIV services to African born individuals in our area. And I can get back to you about more details on specifically Black women.
Mm-hmm. No, thank you. I hear in the community that there's a lack of resources, a lack of awareness, a lack of attention to women, particularly Black and African-born women receiving services, and sometimes, some of our major institutions, Just Us Health, Minnesota AIDS Project, other places are not culturally competent to address that population. And so I'm starting to get really concerned about what are the resources being targeted towards that community of women. So thank you.
You're welcome.
I have a question. Thank you. I have a question or comment from Councilmember Johnson.
Thank you, Mr. Chair. I'm just curious where I've heard talk of vaccines, the research and development side of this issue is at. Do you have any updates on that?
For me, I'm less focused on a vaccine because today we already have pharmaceutical technology to stop the epidemic. What we have today is a functional cure for HIV. With treatment as prevention, when people living with the virus are able to access treatment and take it as prescribed, their lifespans are not any different from someone living without the virus. And that getting people engaged in care is kind of a pathway of, a herd immunity vaccine, similar to kind of what we think about with the flu virus. If enough people get the flu virus, that will stop transmission of the flu. Well, if we get all of our people, if we're able to provide medication services for all of our people living with HIV, that will stop the virus from being transmitted at all. So I'm really focused on how can we today stop health disparities in, access to these life-saving and life-extending antiretroviral therapies for people living with HIV.
I think that's totally fair and a great point, but I also think there's this question around vaccines when you talk about the cost, especially associated with healthcare, and if we can get to a point. So I'm more curious. Obviously, we need to focus now on helping individuals who have HIV, but what about the future? Are we seeing progress being made in research and development, and are we starting to turn a corner there? Do we expect that? And part of this I asked too is kind of, is there hope in that regard for moving beyond treatment as well to a cure? I know it's a functional cure, but it's kind of challenging this notion. I think a lot of people feel this way, that the pharmaceutical industry doesn't have incentives to come up with cures, that there's a lot of incentive to come up with a treatment that then costs a lot of money over time, and that they can continue to make profit off of that. And so I'm curious on that front, are we seeing what we need to from the research and development side, just future thinking as well, beyond the functional cure today and the treatment side of the house.
I'm really glad that you brought up that point about the pharmaceutical industry and the role they play in this issue. Specifically, the innovation that I think there are two innovations, one that has happened within the past 5 or 6 years whose potential hasn't been realized because of pharmaceutical cost increases, and the second, which is on the horizon. So PrEP, pre-exposure prophylaxis, that is a really important pharmaceutical innovation of the past 5 years, which is designed specifically for people who are HIV negative, and it's a 1-a-day pill that if you take it, it can stop the risk of infection up to 90%. So that's a really important path we have here in the near term. The kind of innovation of that is there's research going into, well, can you turn that 1-a-day pill into an injectable that lasts you for several months perhaps? So I can't speak to the kind of bench laboratory work that's happening there, but in the near term, this injectable version of PrEP is something that will be interesting to follow. Returning to your point about the role the pharmaceutical industry plays in a vaccine-like interventions to stop the epidemic, that 1-a-day pill for PrEP is right now a brand name, and only one company makes that. Gilead makes a brand name, Truvada. Truvada was originally a pharmaceutical to treat people living with HIV, so using it as a prevention tool for HIV negative people is the innovation. Getting back to Gilead here, the CDC funded the research that invented PrEP as a method. So right now, there's only one brand name on the market, Truvada, that Gilead controls, that works for PrEP. But in the future, there's no reason why non-brand name, a generic version of Truvada would work just as well, right? But the issue is that CDC, the Yale School of Law and Yale Public Health School recently uncovered that CDC owns enforceable patents on the method of PrEP. So Gilead has the control over the pill itself. The CDC has control over the method. And Yale suggests that the CDC could sue Gilead for infringement of its patents on PrEP and fund programs for PrEP access. So kind of part of to make sure that people know about PrEP, and they could also fund public health programs like the county's Red Door to provide PrEP. So it's really the issue here about affordability is PrEP. Truvada, brand name Truvada, has increased in price some 50% since it was approved for PrEP in 2012. It can cost $2,000 a month here in the United States, but in South Africa, it costs $7 a month. So I will be, as possibly Hennepin Strategy Coordinator, I'll be monitoring and supporting policies that will make PrEP, whether through brand name Truvada or a generic version of that drug, more accessible and affordable.
Thank you. I think that's huge in highlighting that. I mean, $2,000 a month is absolutely shocking. And then you see elsewhere, like you mentioned, $7 in comparison. Mm-hmm. And so it's just really, really, really frustrating because it seems like oftentimes with pharmaceutical companies, they're putting profits before people. And I'm glad that you're able to highlight this specific case where this is a real missed opportunity because of that. Thanks.
Thank you. And I know we're going to get to the action plan. I perused a little bit ahead, so I see that this question isn't answered. So I wanted to ask while we have you here. I read a study about HIV in Thailand and how, it originally basically was an issue in prisons until the king released everybody from prison, and then it got spread to the general population, and that they were on track at one point for 25%, I think, of the population to have to be living with HIV. And epidemiologists went in and found where the key moment of influence was sex workers using condoms or not using condoms. So the intervention was getting sex workers to consistently use condoms. And so that was what stopped that rapid spread. Now, granted, that's a more homogenous society, but have we been able to identify those kind of key interventions that, because I know we have PrEP and we have treatment, but are we seeing behavioral changes that can be intervened in along the way as well from the work that you're doing in Hennepin County?
Yeah, and I think kind of this is the challenge that both Hennepin County and Minnesota as a whole face, is that when you look at who the new infections are among, we can see that our prevention programs are successful, but not for everybody. And in particular, we can see that the proportion of new diagnoses who are among white men is shrinking, but the diagnoses among Black folk and Latina folk of all gender identities and sexual orientations is growing. So unfortunately, the challenge we have to focus on solving is how do we make the interventions that have worked well for white men work for other people, particularly Black and brown folk.
Great. Thank you so much. And thank you for all of that. We had lots of questions and had a good discussion. So thank you so much for all your work.
Thank you. You're welcome.
Noya, you're back up.
Well, I want to quickly introduce one other person. Matt Taburin is the executive director for the Aliveness project, and he is one of the people that originally approached the city to sign on as a fast track initiative city. So I just wanted him to say a few words about that. Thank you.
Welcome, Matt. Thank you.
Mr. Chair, members of the committee, my name is Matt Taburin, Executive Director of the Aliveness Project. And the Aliveness Project is an organization in the 8th Ward that is a community center by and for people living with HIV. We provide a holistic wraparound services. We're a meal program. We provide hungry people with food. We help house homeless people. And we provide wraparound service that keep people in care, keep people healthy, and help folks live self-directed and self-empowered lives. And we also do HIV prevention, testing, and outreach work out in the communities. And it's an honor to be here, and it's an honor to work with you and the Minneapolis Health Department. A little over a year ago, it was an amazing day to stand here with you all and pass a resolution to make Minneapolis a fast-track city to end AIDS. And on that day, we said Minneapolis is a leader in so many areas and has been a leader, but unfortunately, we've been falling behind when it comes to the fight against AIDS, and that's unacceptable. And there is so much more we could do and can do, and we want to link arms together as a community and with our community leaders and make that happen. And we have been working closely with the city over this year, and I can tell you that we have made good steps, but we still have a lot more to go. And those numbers haven't changed in the last year. And so that we know that now is the time for action. As you learned about the major goals that we need to do as a city is get awareness and education and prevention messages and prevention and PrEP in the community. We need to get more people tested. We know that there are a number of people in Minneapolis today who are living with HIV and don't know that and do not know their status. So we know we need to get them tested into care. And we know that there are many people in the city of Minneapolis who are HIV positive, know their status, and for a lot of different reasons aren't in care, aren't in medications. We know that this disease is a disease of poverty, it's a disease of stigma, of discrimination, of homophobia, and that the communities that are most in need are falling through the cracks. And we do really well in Minneapolis in our fight against HIV with some communities, but we know that there are other communities that continue to fall through the cracks and continue to fall behind, and we see those disparities in our health outcomes grow year after year. And as you've heard and will continue to hear today, communities of color, queer folks, and trans folks in particular are most impacted and are most left behind in the services and what outreach we're able to do today. And so as we move forward, have two asks for you. The first ask you hear all the time from everyone is we need more resources, and that's certainly true and something that we will continue to advocate for. But our second ask, and I think that it's a far more important and far more impactful ask, is that if we're going to hit those goals, if we're going to hit the 90-90-90 and zero stigma, we're talking about people, we're talking about real people, and we're talking about the people in your wards. And we need you to partner with us, to work with us, to find those folks, and to let them know that there is a community in Minneapolis that loves them, that supports them, that is here to help them succeed and to help bring them into the effort, both reaching out to folks who've fallen behind, but also reaching out to the folks in your community who are most impacted by HIV and saying, you know, there's some great folks around the table right now, but that table is not big enough. And there's a lot of voices that aren't at that table, and we really need you to help us bring in the right folks to that table so that we're working together to figure out what are the solutions that are going to work best, and that solutions that work in one community aren't going to work in another community, and we need your help to make sure that those communities are at the table. So with that, it is an honor and joy to be here and to work with you in the city, and look forward to these efforts as we move forward. So thank you.
Thank you so much. Council Vice President Jenkins.
Thank you, Chair Cunningham. And Mr. Tiburon, I just want to say congratulations on your recent appointment to Executive Director of the Aliveness Project. It's awesome. I'm going to ask the same thing I asked Jake. Are you guys doing any programming, targeted outreach for Black and brown women who are being disproportionately impacted by this disease, even more broadly than Black and brown communities, which has already been discussed? Any thoughts about that?
So, Councilmember Jenkins, that's a fantastic question. I know just on Friday, I was having lunch and meals with members. We had a meeting that morning for African American and African born women living with HIV, and it was a sort of joint effort with Aliveness, Just Us Health, and African American AIDS Task Force, and it was a sort of self-care type of group, and they were putting together flowers and doing sort of different activities and then all having meals together. And so I had an opportunity to talk with a number of them on Friday, and there's definitely a lot more work that we need to do. And the stigma that particularly women of color living with HIV feel is a different stigma, and it's a different issues than other communities. So it's something that we know. We know there's a lot more work that needs to be done, and that there is some good work happening, but we need to build off that, and we need to particularly empower those communities in particular to say that you are a part of this solution and you need to be at the table, and that you are as important as every other member of the HIV community.
Thank you so much. That's great. You know, I really just feel like if we're gonna address this disease and get to our fast track goals, we really have to be fully inclusive of the entire community that is being impacted by this, you know, chronic illness now that people, you know, through the help of Truvada and medications like PrEP, people can live longer lives, but only if they are getting tested and getting, you know, becoming aware of their status and having targeted outreach. And sometimes the outreach that is specific or successful with gay white men is not the same outreach that's gonna bring in women of African and African American descent. So glad to hear that you guys are aware of this issue, and in any ways that I can be more helpful, you know, beyond just bringing up the issue, please let me know.
Wonderful.
Great. Thank you so much. Thank you for being here. All right, Noya, I think for real this time. You're up.
Okay, actually, with asking permission to have one more speaker, and I will.
Yes, please.
I will abbreviate our portion of the presentation to accommodate this. But I think it's important to hear from our community partners.
Yes, please. Thank
So
you.
Cree Gordon is with the Youth AIDS Project.
Welcome.
Hi, good to see y'all again. So we heard about disparities. So I want to talk about two things that we're actually working on to reach some folks in the community that we're doing a little bit different that we weren't doing before. So in my role as prevention coordinator at the Youth and AIDS Project, we are one of several organizations that the state and Hennepin County have given Black men who have sex with men testing grants to. And if you don't know, we have a very small population of Black MSM in the Twin Cities. And so to have 7 or 8 different organizations all trying to target this one population can be very challenging. So one of the things we did at the beginning of last year, myself and William Greer, who now works at the Red Door Clinic, we created a group called the African American MSM Underground Railroad. So we are a group of providers, frontline staff who are all contracted to reach Black MSM. We're specifically frontline staff, so no leadership can be part of the committee to take ego out of the room. I currently serve as Harriet as our leader because we're the Underground Railroad. But we get together and we organize community events with each other because we realize in creating community and creating space, it's easier to then have conversations about HIV, about PrEP and treatment as prevention and things that are happening. So that's been going well. And so that's one thing. And then I also serve on the Minnesota Planning Council for HIV care and prevention. And I sit in the Disparities Elimination Committee. And one of the things we're currently working on to better identify how many trans folks in the state of Minnesota have HIV is we're drafting a provider letter to get providers to help better track gender identity. So of the roughly 9,000 folks living with HIV in Minnesota, about 2/3 of them don't have a gender identity in their records at the state in the epidemiology data. And so we're trying to get providers to update that to better track how many trans folks we have in the state, because that's how we get allocated resources from the federal government, is based on numbers. So if we don't have the data showing how many people, we can't get the resources to reach the communities. And so that's happening. And I know we hear about disparities a lot, but we often don't hear about the work that is being done to reach these communities. So that's kind of why they got me to speak up today. So we are working on things. And Councilmember Jenkins, MDH does fund one organization to do Black testing and prevention with Black women, testing and prevention for Black women. I don't want to guess at what organization it is, but I will call MDH this afternoon and then I can get that to you. So then that way you know who's working on that.
No, thank you, Cree. That would be wonderful. I know they just stopped funding one organization that was working on that.
That might have been the one organization. So maybe, and that's something that we can take on as the Disparities Elimination Committee of the Planning Council. So I'll bring that up at our next meeting.
Right, and I keep harping on this. I'm sorry.
No, but it's a real issue, though. I think often
it's a very real issue,
and not just like Black women. I think so often we ignore women in having the conversations about HIV. There a lot of times when women see their gynecologist and they ask about an HIV test, they're told that they don't need it, or even when they ask for like an STD screen, HIV is an opt-in test, and so you have to specifically say you want an HIV test. They won't give you one if you ask for an STD screen, and I don't think many people know that. And so I think oftentimes we because in the United States, like many westernized countries, it has been gained by men who've been mostly affected. But a quarter of our new infections in the state are women. So to me, that's a disparity. And so I would love to work with you. And like I said, like I think that's a task that the Disparities Elimination Committee, as part of the HIV Planning Council, can also help address.
Right, and I think you guys will have to take it on. And I do want to acknowledge, I know like in the Native community, the Indian Women's Health Board, and so many other organizations that are really, because HIV and AIDS is a huge problem in the Native American community as well. But there just seems to be a lack of dialogue and awareness around Black and Latina women in this disease, and so I'm really just trying to elevate that issue amongst agencies and organizations to encourage that dialogue and offer my support and help in trying to reach out to those communities.
Awesome. Sweet. Thank y'all for having me.
Thank you so much. Thank you for the community partners who are here. It means a lot to have you all here, to be able to hear about the work that you're doing, hear your perspective. We had a really robust conversation already, so thank you so much for being here. Back to you.
All right, thank you. Well, we're going to speed through quite a bit of this stuff. I just want to give a summary of a little bit of the work that we've been doing and how we're going to be moving forward with this work. So this is another project that I took over shortly after I started working for the Minneapolis Health Department, because the employee that had been working on it left. And so as Jake pointed out, this is a newer issue to me as a service provider, but it's been interesting learning about it, and it's certainly been interesting working with our community partners on putting this plan together. There are 4 goal areas in the City of Minneapolis Action Plan related to the Fast Track Cities Initiative. The ultimate goals are the 90, 90, 90, 0 that I named immediately before our community partners got up to speak. We have goals in each of the areas. There's a few highlights I would point out here instead of going through each of these slides individually like we had planned. One, we were very intentional about not replicating the work of our partners like Hennepin County and the state of Minnesota, both who have very robust plans as it relates to HIV and AIDS. So a couple places in our plan, you will see that we simply said we are going to support their work in any way that we can and any way that they might ask us to do that. In other areas, we are going to use things that we are good at to help support that work. For instance, the Minneapolis Health Department has a fairly good reputation and history of engaging in communities of color, and we can help go out and speak to these communities and gather information that's relevant to providing the best outreach as it relates to testing and getting people treatment for HIV. And so we're going to use our strengths as a health department to support the work of our partners that are already doing some of this work. Our plan is to take a few of these action steps each year and prioritize our work year by year so that at the end of 4 or 5 years, we'll have gotten through all of these action steps. Our first priority is going to be something that Cree had actually spoken to, that now when you go into your clinic, you have to opt in to get tested for HIV. And if you don't have a clinician that asks you, and you're not actively thinking of it, it's not going to come up and you're not going to get tested. We want to work with clinics and others to make it an opt-out versus an opt-in. So that way, if you're getting tested for STDs, HIV is automatically included in that panel and you will just be tested. If you don't want to be tested, you would have to opt out. But we can work with our partner clinics in Minneapolis to help make something like that happen. Another example would be to essentially create a good housekeeping seal of approval for clinics, that if you have opt-in testing or opt-out testing, if you provide care that is culturally sensitive and population sensitive. And if you provide treatment, we will give you some designation, then advertise that designation to the community. So to let people know, if you want good, solid care, testing and care, if you are a person at risk of or living with HIV, this is a clinic to go, because we know they will take good care of you. And again, this is something that we can work with our community partners on. And then finally, we're going to be working on the stigma issue, the discrimination and stigma issue. We feel like there's some things right here in Minneapolis, in the Minneapolis governmental structure, that we can work on, like go to the Civil Rights Department and say, what are you doing in terms of discrimination against people living with AIDS, and see if there aren't things that we can implement for how we do business here at the City of Minneapolis. And with that, I just wanted to end, like with the opioid work, I wanted to put a few things forward for your consideration as we move forward with this work. Part of the ongoing work is to expand the already existing fast track task force. Currently, there's representatives from the mayor's office, Councilmember Bendner's office, Councilmember Cunningham's office, and Councilmember Jenkins' office. Hennepin County and a few other community-based organizations. If there are others that you think we should be having on this task force to advise our work, we would certainly welcome their names, and certainly welcome a conversation with you about having that person join our work. The action plan, as I said, is to pick out 2 to 3 of the action steps to work on each year. Are there any of them that you believe should be prioritized as you read through those? And then one of the priorities, if funded, will be to gather quantitative and qualitative data from impacted communities about the extent and degree of both internalized and external stigma. Are there individuals or groups from your ward that you believe we should specifically include in this process? And with that, I will wrap up our presentation. Thank you, Chair and Council.
Thank you. Council Member Goodman is also involved in this work,
Yes.
correct? Okay.
Yes.
Yeah, I want to give her a shout out to her leadership in it, actually, because she was really the one who brought a lot of energy,
Right.
enthusiasm to us. So shout out to Council Member Goodman on that. Are there any thoughts on these questions? Well, I'll just add that I think I really like the opt-out testing, for that to be a priority. I really like that a lot. It feels pretty straightforward. And I was actually surprised to find out in my own life that that wasn't an automatic thing. And so I'm grateful that this is being seen as a strategy. And it feels, like I said, pretty straightforward. In our school-based clinics, is HIV testing available? Awesome. And are we advertising that?
Well, actually, ours is.
Yeah, would you come up to the microphone? Thank you, Coral. Yeah, I know, we're just having a conversation.
I know, I apologize.
No, it's
Good
okay.
afternoon, everyone. Yes, we do. We actually have, we follow CDC protocols, and currently we provide the testing. We do the opt-out option.
Great.
And we do rapid testing, so.
All right.
Yeah.
School-based clinics. Way to go. Thank you, team. All right. Councilmember Gordon.
Well, I really appreciate the idea of prioritizing housing on there and actually working with CPED. I think that was one of the action steps there and the Housing Coalition. And we do get over $1 million from HUD to help support housing for people with HIV. So I think, and I know the RFP is out there right now, so that also might connect with the advisory group. Once that somebody responds to the RFP and we're working with somebody to provide the housing, maybe loop somebody from them back in so that we can kind of tie that together.
Okay.
I have the Fremont Clinic in my ward, so I would just put them on the list of folks who should be engaged, because I know they're doing a lot of community-based work. So, all right, are there any other questions or comments? Great. Thank you so much. Thank you, everyone, for all of your work on this topic. I'm really excited to see the city be stepping into this space in such an active way, really action-oriented steps. And so thank you for your leadership. And I ask my colleagues to chew on these questions a little bit more. And if there's anything that comes to mind within your wards, to please make sure we bring that forward to NOYA. So thank you so much, and much appreciated, Commissioner, as well. So thank you.
You are welcome. And I would note that I've made note, Councilmember Jenkins and Johnson, of your questions, and then we'll keep track of that as well. And then I would be remiss if I didn't give a shout out to Sarah Shealy, who joined me in this work about 6 months ago and will be carrying it forward on behalf of the city. Thank you.
Thank you, Sarah. All right, so I would like to make a motion to receive and file an update on the Fast Track Cities Initiative. All those in favor, please signify by saying aye. Aye. Those opposed say nay. The ayes have it, and that item carries. Seeing no further business on the agenda for today, we are adjourned.